So hey everyone, I hope everyone is well. Thank you so much for signing up. I think we've actually had a bit of a record sign up this month, which is absolutely phenomenal to me. Absolutely amazing that we managed to have that many people signing up to the webinar, and hopefully I still continue to give value. I was not available in December. Unfortunately, my daughter wasn't very well. So I think I'm going to almost selfishly ask you guys, if possible, could you put a spare a thought or a prayer towards her because she's still a bit sick, but getting better slowly. So I'd really appreciate that. What I'm going to do is I'm going to keep the chat open. As usual, we were able to kind of talk to each other during this thing, and if I get things wrong, I get things wrong. We can talk to each other, and I've learned a lot from doing these for people as well, where I've kind of misinterpreted something and someone's pointed out. So there's no kind of ego, anything like that here. I'm not trying to pretend to be like the go-to person. I like to teach. I like to go through cases, and if you're a bit of a radiology nerd like me, then this is going to be great. So you hopefully got the link. If you do have any problems with accessing the link, then do let us know in the chat, and we'll try and sort that out. We've got, yeah, plain film webinar, monthly webinar number 20. So this has been going on for a while. So this is really, really great. So let's go through case number 20. And the way it works, I'll go through things and there'll be varying difficulty of cases that we do. Yes, of course, some things will be very, very straightforward because some people are very good and they've done a lot of radiology. And there'll be some cases that people may struggle with a bit, and that's fine too. So, well, let's have a look at this one. And obviously, if you think you know what it is, then go for it. But this person's got a significant amount of pain in their knee. And the problem is, like, you've got this X-ray, and first off, you've got to try and think about, okay, first, what can we see? What's going on here? And we can see that there is some sort of calcification here. Can you see that? This kind of linear calcification. So when you get this linear calcification like this, you got to start thinking, okay, so there must be kind of an older person, right? There must have got some vascular calcification. So that's kind of a bit of a clue as to what's happening here. And then what I always do, I always kind of go around every single contour like this and draw all the way around, all the way around, all the way around like so, and just make sure that I can draw it around nicely to look for whether there's any sort of fracture or anything else like that. And again, with the fibula as well, you go all the way around, all the way around, all the way around, all the way around like so, all the way down like so, all the way down like so. That looks okay. When you get to this area here, you can start to see that actually there's a bit of a punched out area over here. The intercontinental looks a little bit large, actually. It looks kind of big. It doesn't feel like it should be that size. And coming up to the more peripheral aspect here, there's another sort of punched out area over there. And coming to this area here, which is the medial aspect, there's another punched out area. Can you see that over there? So with regards to the rest of the knee, I don't think I can convincingly say there's any sort of soft tissue lesion. I can't see anything sort of going into there. I can't see any soft tissue lesions within there and no abnormal calcifications. Coming up to that suprapatellar region, you can actually see that there is a little bit of fluid located there as well. So there is a bit of a suprapatellar joint effusion. So you've got an older person, you've got some vascular calcifications, and you've got a suprapatellar fusion. Now, fair enough, someone's gone for where this could be a tibial fracture. Now, the reason why someone may think it's a tibial fracture is because, yeah, you do have these very abnormal areas located here, 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 and here. Now, you can get very complex tibial fractures where, yeah, they could be comminuted, which is basically a fancy word for um, a complex tibial fractures, but you don't really see any linear abnormalities going anywhere else. These are very well defined and very, very well punched out. If it was a tibial fracture as well, you probably would have a lipohemarthrosis where there'd be like a flat line over here, right? Because the blood and the fat from the fracture would kind of settle in a particular area. But this, you don't really have that here at all. You just got this supratellar fusion and you've got these sort of punched out areas over here. And this widening of the intercondylar notch is also something to be taken into consideration. Now, if I said there was no trauma, you've got to start going down the lines of, okay, so you've got no trauma in an older patient. What could this be? So then you've got to start thinking about, is this inflammatory? Is this some sort of rheumatoid arthritis? And I think we've got a poll. So hopefully Becky can give that poll out. So that poll's coming out. And if you could just tell me what you think it is. And in the meantime, I will start to explain. So, like I said, I don't think we can go down the idea of this being a fracture because we can't really see much in the way of lipohemarthrosis. You don't see any linear abnormalities anywhere. Osteoarthritis is not a bad shout because, yeah, they are older. But one of the ways I remember osteoarthritis is, you use the word loss, Loss. Yeah. So L is for loss of joint space, O is for osteophytosis. S is for subarticular sclerosis, and the other S is for subarticular cystic change. So in this area, you don't really see loss of joint space. So if there's no loss of joint space, you can't really go down the idea of this being osteoarthritis. And you do have a little bit of a loss of joint space on the medial aspect, but not really enough to tell you, like, give you these very abnormal looking areas, right? So rheumatoid arthritis, potentially, but one of the things that's taken away from rheumatoid arthritis is the fact that they've got what is known as a um, periarticular erosive change. And looks like, yeah, so 58 people, 58% went for gout, and that's exactly what this is. And so I'm going to share those results so everyone can see. Scleroderma, you'd think about, multiple punctate calcifications, chondrocalcinosis, that kind of thing. Doesn't usually hit the big joints. But gout, it does. It hits the big joints, and you get these periarticular calcifications, right? Periarticular erosive changes, and you can get sort of a widening of the intercondyle notch. So obviously, right now, anyway, we're all radiologists, aren't we? So do we just say that, or we need to say something else, don't we? We can't just stop there. So we've got to say to them, okay, so we're thinking this could be gout, and therefore, if we think it could be gout, we have to think about doing a aspiration and sending it off for urate, and also looking for crystal arthropathy within there. So gout is essentially crystal arthropathy, and it could be this patient has multiple attendances. So this could be one of many. So having a look at previous X-rays is always very useful because it may not have changed all that much, or maybe some of these erosive changes were there from previously, and we're just seeing new ones that have turned up, and that's why they've come in with pain. But also other big joints can be affected. You can have the ankle joint, the big toe, which is the classic, isn't it? The big toe is the classic one that people would say is being affected. Right. So what we'll do now is go to the next case. Hang on.